Yeah, so this is a work that was just published in Blood. We're very excited about. So it's a paper where we looked at the genetics of therapy-related MDS and AML, or therapy-related myeloid neoplasms. And these are MDS or AML that occur in patients who have been treated usually for another cancer, often a solid tumor or lymphoma or multiple myeloma. And it's really one of the sort of devastating consequences of treatment for cancer is you give them chemotherapy, hopefully to either, put them in remission or cure them of another cancer, and then they get a deadly leukemia from it. And we know that these leukemias are really difficult to treat, and they often have P53 mutations, which are really associated with a very poor prognosis in MDS and AML. And so in collaboration with the team at MD Anderson, we looked at a large cohort of patients with therapy-related myeloid neoplasms that we had genetic information on. And then we could associate the genetics of their leukemia with their prior chemotherapy exposures and other clinical characteristics to try and figure out whether or not certain therapies are really associated with specific genetic subtypes of therapy-related myeloid neoplasm. And what we found was that prior exposure to lenalidomide was associated with P53-mutated MDS and AML in particular. And we've known for a long time that lenalidomide maintenance in patients who've had an autologous transplant and multiple myeloma is associated with increased risk of MDS and AML. And so this sort of fits here. We're really showing that it's an association with the P53 mutated subtype, which is a particularly poor prognosis. And so taking that information, we were then able to model this in a mouse system to actually look at what the sort of mechanism of this is. And what we could show is that if you take mice that have sort of a small number of P53 mutated cells in their blood, so we use a chimeric transplant model for that, and you treat them with lenalidomide, the P53 mutant cells start to grow out. And this is really analogous to clonal hematopoiesis, where patients maybe have a P53 mutated cell in their blood, but don't have overt disease yet. And what we think is happening is the P53 is, the lenalidomide is sort of suppressing the normal bone marrow, which allows that P53 mutant, those P53 mutant cells to grow out. As they expand, they can acquire additional mutations and then go on to develop into a leukemia. And then one other important factor is that we think this is due to a very specific target of lenalidomide called casein kinase. And that it's the degradation of casein kinase that is important for mediating this sort of differential specificity between the P53 mutant and wild type cells. And there are new analogs of lenalidomide coming into the clinic that don't degrade casein kinase. So pomalidomide is one, which will be used for a long time in multiple myeloma, and then Iberdomide or CC220 is another that is in clinical development. And so both of those drugs maintain their anti-myeloma activity because they still degrade other substrates of lenalidomide, but they don't target casein kinase. And so they might be a safer alternative. And I think it's something that we'll want to explore in the future.